Where do I put some ice here? How about my tie?
It'll be fine.
Okay. All right. Well, let's go ahead and get started. I'm going to review the kind of gamut of adult spine. I'm not going to do anything about any pediatric deformity or pediatric topics. Now, let's start with cervical disc disease. Cervical spondylosis and lumbar spondylosis, for that matter, are really part of the natural aging phenomenon and should be considered a normal process. The pathology that you see includes disc desiccation, narrowing of the disc, bulging of the disc, and segmental kyphosis. Each cervical segment is slightly lordotic, 2 to 3 degrees of lordosis. And as you lose disc height, you lose that intersegmental lordosis, and it's important for the pathology and the treatment in some circumstances. You see uncinate spurring and facet arthrosis, and on occasion you see true disc herniations. The most common level is C5, C6, followed by C6, C7, and C4, C5. Among the risk factors that have consistently been identified are a history of lifting, a history of cigarette smoking, presumably because of coughing, in addition to poor circulation to the disc, and a history of driving certain types of motor vehicles. There are basically 3 syndromes with lots of overlap that you can see in cervical disc disease. One is discogenic neck pain, consisting primarily of axial neck pain, radiation maybe into the trapezii. The next is radiculopathy, pain down a dermatomal distribution, and that can be from a hard disc, like an osteophyte, and a soft disc, like a true disc herniation. Those terms, hard disc and soft disc, you don't see quite as often as you used to, but some people still use them. You'll see them in the literature. And the final is myelopathy, dysfunction of the spinal cord. It's important to be aware, almost every year there's a question about the incidence of false positive MRI scans in asymptomatic individuals. And they're not truly false positive in the sense that they accurately reflect what the spine looks like, but they don't accurately reflect the person's symptoms or lack thereof. It's hard to remember all these numbers, and there's a lot of numbers, but probably the easiest thing I think to remember is under the age of 40, in the cervical spine, 14 to 15% of patients, or of people, will have an abnormality, disc degeneration, bulging, HNP. Over the age of 40, it doubles to 28%. And obviously, there's a continuum, but that's probably an easy way to break down the numbers. And for the most part, plain X-rays are completely nonspecific in screening somebody for cervical spine problems. They always ask questions. There'll always be a question in either the cervical or the lumbar spine or both, because they're easy to write, about the neurologic findings. So you really need to know the cervical dermatomes. You need to know the reflexes. You need to know the major motor groups. And remember, in the cervical spine, and we'll look at the lumbar spine later, in the cervical spine, it is always the lower numbered group. So it's C5, C6, it's always C6 involved. Okay, at C4, C5, it's always C5. At L4, L5, it's usually L5, but not always. But in the cervical spine, it's always C5 at C4, C5. Okay? In terms of management, there's some non-surgical things, and again, it depends on the syndrome you're dealing with. They include non-steroidal anti-inflammatories, the use of a collar, moist heat, and these things are actually very effective for most discogenic neck syndromes and even radiculopathies. Physical therapy can be helpful. Traction is very effective sometimes, and at Georgetown, we use injections a lot. Cervical facet injection, cervical nerve root blocks. We have neuroradiologists who are really slick, and it really is effective, at least in short-term relief. And many times, you'll abort a syndrome that in somebody who's absolutely convinced that they're either going to die or going to need surgery, or both sometimes. I find injections to be very helpful. Surgery is indicated for persistent, painful radiculopathy, and you really shouldn't be afraid to operate when it's indicated, either in your practice or to answer that question on the boards. But you really need to see clear-cut indications. Far and away, the most common indication in cervical or lumbar radiculopathy is persistent, painful radiculopathy, and for the most part, that's somebody who's had symptoms for at least 6 weeks that have either not gotten better or have only gotten minimally better. Occasionally, you'll see someone with progressive, significant weakness, but that's relatively uncommon. Myelopathy, and we'll look at that in a minute, is felt to be, for the most part, an indication for surgery if someone clearly is myelopathic, certainly a young or middle-aged adult. And you should try to avoid getting advanced imaging studies, particularly MRI scan, except as a preoperative evaluation or with someone who really has chronic symptoms that are unexplained. But it's a mistake in practice and it's a mistake on the test to see somebody at 2 weeks with a decreased reflex or with neck pain and say, well, let's send you off for an MRI scan. It's a needless waste of resources. You have that whole thing of false positive MRIs, and many times you sort of fuel the train of an operation that the patient is better off never even thinking that he or she might need. So you really should think of the MRI scan as a preoperative evaluation. Certainly in orthopedic surgery and in orthopedic test taking, anterior cervical discectomy and fusion is the most common operation. There are alternatives. There's anterior cervical discectomy without fusion, which a lot of the neurosurgeons still like to do, or some neurosurgeons still like to do. It is much less common nowadays, particularly since the neurosurgeons have figured out how much money they can make doing fusions and plating as well. It's much less common to see ACD without fusion, but it is still certainly a viable option. I doubt they're going to make you decide between ACD and fusion versus ACD without fusion. Another option is a keyhole foraminotomy, which is a posterior approach, which I find is good for a unilateral, either 1 or 2 level radiculopathy, particularly in somebody who has multi-level spondylotic changes, where you really hate to say, well, I'm going to fuse this 1 level and there's 3 other discs that are bad, or I'm going to fuse these 2 levels. So that's a nice indication for a keyhole foraminotomy, and there certainly is a role for that. Again, the subtleties of picking what operation to do are probably not going to be highlighted on your test. The one thing is I would avoid a laminectomy. It's, in general, laminectomy in the cervical or thoracic spine is just, if you're guessing on questions, just avoid laminectomy because it's rarely the answer on an orthopedic test. There is still some debate about auto versus allograft, and there's a fair amount of debate about plating. It's becoming more and more common to see it done. I think there's very little literature that supports plating for single-level fusions, which still have a very high fusion rate. On the other hand, 2 and certainly 3-level ACD infusion, if they get you into a situation where you're doing that, hopefully they won't, I certainly would consider a plating. And certainly a 3-level ACD infusion, if you've got yourself convinced that's the right answer, and it rarely is, an ACD infusion with 3 levels, without plating, without a posterior approach, just a standalone 3 horseshoe plugs, is probably not going to work. So I would stay away from that and look for something else like either plating or supplementing it posteriorly. You need to know the Smith-Robinson approach since it's so commonly done, and it's the kind of thing they like to ask. Know the intervals. Split the platysma. Go through the interval medial to the sternocleidomastoid and lateral to the cervical strap muscles. You need to know the intervals that you go through on the Smith-Robinson approach, and you need to know the complications. And that complications are relatively easy to ask questions about, so that throughout the week probably you'll see a lot of highlighting on complications. Among the common complications in cervical spine surgery are injury to the recurrent laryngeal nerve. About a 1% incidence. Most of the time it resolves spontaneously. If it doesn't resolve after 6 weeks, the treatment is ask your ENT colleague to do a direct laryngoscopy, and if the vocal cord isn't moving, they can actually inject like a Teflon-like material into the vocal cord, which has pretty good results. But it is a relatively common complication. Airway complications are talked about, not usually in disc surgery, but in repeat surgery, corpectomies, and patients with myelopathy, and you need to be aware of that risk. Injury to the vertebral artery, which most commonly occurs with the use of a high-speed burr. I know that's been on the OITEs, if not the boards. The most common time that a vertebral artery injury occurs is during use of a high-speed burr as you drift laterally. Neurologic complications are rare, but can be devastating. Probably about 1 out of 100 cases there's a neurologic complication, and maybe 10% of those are either severe quadriparesis or quadriplegia. And certainly the most common complication that you'll be asked about is pseudarthrosis. It's about 10 to 12%. In Smith and Robinson's original report, it was 12%. In a report by Bowman recently, it was around 10% for 1-level fusion. So it still is a fairly significant complication. And you certainly can't let people tell you otherwise. It's up to as high as 45% for 3-level fusion. So that's really an unacceptable failure rate, even though not all of them are symptomatic. And you need to be very careful about jumping on an asymptomatic pseudo, either in your practice or on the boards, because if they're asymptomatic, it is the wrong thing to do to reoperate. You follow the patient, see how they do. If they are symptomatic, and certainly if you can clearly document motion, then the traditional answer has been a posterior fusion with either wiring or instrumentation. Bowman has written up a series of doing a repeat anterior fusion. I think either approach is acceptable, but you should know that certainly if you have a painful pseudoarthrosis, if there's documented motion on flexion extension views, then repeat surgery is a reasonable option. But if it's pain-free, don't fall for the trick of wanting to operate on it. Cervical myelopathy is another syndrome that we see as, in cervical degenerative disorders. It is more common in individuals who have congenital stenosis. Certainly it's seen a lot with spondylosis because of the pathology that we see. There's anterior bars that come into contact with the spinal cord. There's kyphosis, which drapes the spinal cord across the anterior pathology. And there's also a condition called ossification of the posterior longitudinal ligament, which is more common in Asians, but certainly is seen quite commonly, or relatively commonly, in this country as well. The clinical manifestations of cervical myelopathy, the most significant one is gait deterioration. And the classic is a broad-based, shuffling gait. You want to ask the patient to heel-toe walk, which will many times bring out the fact that they really are quite unsteady on their feet. Now, there's lots of reasons that elderly people have balance problems and even gait problems, but this is one of the things that you should think of. And as an orthopedist, if they're giving you this, you need to be thinking about cervical myelopathy. And certainly if you see someone coming in who maybe has low back pain or is sentia with a lumbar problem, and they have brisk reflexes, an unsteady gait, you need to think about cervical myelopathy. You also see upper extremity problems. And actually, in my practice, I would say if you ask patients about it, they'll talk about difficulty with hand function as much as you'll find gait problems. The gait problems are kind of the hallmark sign or symptom, if you will. But if you ask people, do you have trouble buttoning buttons, if somebody who's got a particular hobby, crocheting or something like that, you will find from people that, yeah, I don't have that fine motor function in the hands. There's a condition called myelopathy hand that they may ask you about with loss of the intrinsics. You'll see ulnar drift of the little fingers. And then the classic thing is to find upper motor neuron signs, although certainly you don't always see upper motor neuron signs. And if you see some of these other physical findings in someone who is really kind of rigid on physical exam, the fact that they don't have a Babinski sign or the fact that they're not hyperreflexive, particularly in the lower extremities, where you tend to lose your reflexes as you age anyway, I would not exclude the possibility of myelopathy. It's relatively uncommon to see bowel and bladder dysfunction in cervical myelopathy. You can see it, but it's not that common. The natural history of cervical myelopathy is somewhat debated, and 30, 40, 50 years ago when this was looked at, I guess at least 40 years ago now, it used to be taught, and when I was a resident reading about it for the first time, it used to be taught that the natural history was uncertain and you needed to follow patients, and many times they stabilized. But more recent studies, I think, have shown a more kind of perniciously bad natural history. And as a result, more and more people, I think, feel that the presence of cervical myelopathy in certainly a middle-aged or up to 60-year-old adult, the presence of myelopathy in and of itself is an indication to do surgery. We'll get to that in a minute. But suffice it to say, I think most people feel that myelopathy will progress eventually. It doesn't necessarily progress relentlessly or rapidly, but it will eventually progress. And the problem is that historically at least, the teaching has been that surgery keeps you where you are. It may not really be true, but that it keeps you where you are. So you want to intervene before somebody is using a walker, because if they're on a walker, there's no guarantee that with an operation you're going to get them back to a cane or ambulating without aids. How do we make the diagnosis? Well, in addition to history and physical exam, there are some X-ray findings that are relatively helpful in cervical myelopathy. They're certainly somewhat nonspecific, but they're relatively helpful. The sagittal diameter of the canal is really, for me, the most helpful thing. The normal sagittal canal diameter is 17 millimeters from front to back, and that includes the presence of the osteophyte. If it gets below 13 millimeters, then that is diagnostic of cervical spinal stenosis. Conversely, if you look at somebody's X-ray and they have a capacious cervical spinal canal, chances are they're not going to have cervical stenosis. And chances are that they're not going to have cord compression, unless, for instance, maybe they have a big disc, which you see every once in a while. Pavlov and Torg tried to create a ratio looking at the size of the vertebral body versus the size of the canal, with the idea being in big patients, and they were looking at specifically at college and NFL football players, you couldn't really go by the absolute numbers. Their ratio is really not as helpful as the absolute numbers. For one thing, using 0.8 is actually far too, I guess it would be not sensitive, or too sensitive, not specific enough. A lot of people have a Torg's ratio of 0.8 and really don't have any cord compression when you get MRI study. The other thing that you frequently see, or you'll almost always will see, spondylosis, loss of lordosis. So if somebody comes in and they have a normal cervical spine x-ray without a lot of osteophytes, without a lot of collapse, and they have a normal sagittal canal diameter, chances are they're not going to have x-ray or MRI evidence of cord compression. Now the MRI is really nowadays the test of choice, and it will show stenosis, it will show cord flattening, and it will pick up in some cases. You can barely pick up here, I think, a little increased signal in the cord on the T2 image. When you see that, that's something to me is a relatively absolute indication to do surgery if somebody's healthy enough to have it. You read about the compressive ratio, and the compressive ratio is the ratio of the AP diameter of the canal to the transverse width of the canal. The AP diameter of the cord to the transverse width of the cord. It's really probably for research purposes only, but at least knowing the number. The spinal cord is a malleable soft tissue structure, and it will actually compress in the AP diameter and get bigger in the lateral diameter when it's being compressed. And so when you look at the cord and follow it on serial cuts, and all of a sudden you realize not only does it seem to be squeezed front to back, but it's actually getting bigger side to side, that's pretty significant compression when you see that. The number to remember, I doubt you'd be asked this, but is 0.4. The AP diameter should be more than 40% of the transverse side to side diameter. If it's less than that, then that's a compressive ratio that is an ominous sign. The efficacy of non-operative treatment in cervical myelopathy is debated, and many people say once you see it, it's really an indication for surgery, and I probably wouldn't take issue for that. Mostly what you do is the same thing you do for cervical disc disease otherwise. A helpful thing might be to put the patient in a collar. I'd be careful about traction, because anytime you're applying traction across, particularly if it's a kyphotic deformity, you put the cord at some risk. Now, the amount of traction we use for symptomatic relief in the cervical spine is probably not that big a deal, but traction in kyphotic deformities with cord compression, whether it's a 2-year-old baby or a 90-year-old little old lady, you should approach with some caution. The one thing that I would tell you is you need to be careful. I certainly would not operate on someone where you've kind of made the surprise diagnosis of myelopathy on the first visit. So in other words, if somebody comes in complaining of low back pain and you happen to see, gee, you have Babinski signs and hyperreflexia in the upper extremities, you need to bring that person back a month later, because I've seen a number of patients where those increased reflexes, the Hoffman sign, for instance, many times won't be there the next time you examine them. So if they don't have the whole picture of cervical myelopathy, if it's just sort of some hyperreflexia, I would certainly bring that patient back a month later and check and see. But if you have a clear-cut case of myelopathy, and certainly if you see gait changes, if the patient describes progressive dysfunction where they can tell you, gee, I know my hands aren't working as well now as they were 6 months ago, or certainly any kind of significant hand involvement, that's a relatively clear-cut indication for surgery. In some of the older literature, going back even as much as 10 years, people used to talk about, let's say, 70 years old as a cutoff. Well, I'm sure you've all seen in your residency the fact that people in their 70s are well, many times I know my parents are delusional enough to think they're still middle-aged in their 70s. So I would say that somebody in their 70s is certainly young enough to consider surgery, and it's really their overall health more than anything else and their degree of function. It would have to be a relatively infirm patient who, for me to tell someone who clearly has myelopathy that they're not a candidate for surgery, and it's the exception at Georgetown. My partner does most of this nowadays, but it's the exception for us, really, for him to turn anybody away just because they're just flat out too old for this. What's the appropriate surgical treatment? Well, in orthopedics, most of the time, and mostly what they're going to ask you is for anterior surgery. Most of the patients that you will see will have anterior cord compression, and I realize that these studies aren't showing up really well, but Most of the time there's loss of lordosis, if not frank kyphosis in these patients. The compression is coming anteriorly, and if you have a stone in your shoe, as I heard somebody say once, if you have a stone in your shoe, you don't take the top of the shoe off, you reach in and get the stone out, or your foot's going to keep hurting. And most orthopedic surgeons feel that anterior surgery is usually the right answer. The most common thing that the people who do this a lot like to do are corpectomies and strut grafting, and you can do that certainly for 1 or 2 levels. Some people will do it for 3 levels. An alternative, depending on the degree of compression and the degree of disability, is multi-level anterior cervical discectomy and fusion. There's still a great deal of controversy as to the appropriate way to stabilize this. Whether to use a plate for 1 level, 2 level, 3 level. The problem if you don't use a plate is that a strut graft can dislodge, and the masters can put it in and rarely talk about dislodgement, but for most of us who don't do it all that often, strut graft dislodgement is a relatively common, at least concern. It doesn't necessarily happen all that often, but we worry about it a lot. So there was a big enthusiasm for plating. The problem is that plating may actually inhibit fusion because it prevents the vertebral bodies from settling, and as you know from any bone healing, you want a little bit of compression to facilitate healing. So there's still some controversy about plating. One of the things that I think you will see, you've probably seen it in your residency, and you may well see it on a test, is if you have a multi-level corpectomy, certainly if you get up to a 3-level corpectomy, I think the people who do this a lot more and more favor a combined anterior and posterior approach. And it seems like a lot of surgery. It is a lot of surgery, but it's probably not as much surgery as having to go back and reoperate from the front either a day later or a year later if they don't fuse. So it's much more common nowadays to do a corpectomy and strut graft 2, 3, even 4 levels, and then go posteriorly and do a plating posteriorly. Some authors use a halo. The problem with a halo, as we'll see in a minute, is that it's really not ideal fixation for the lower cervical spine. So it's helpful, it makes you feel better that you've done it, but it's really not definitive fixation as much as rigidly fix them either front and back would be. Another approach is posterior. The problem with the posterior approach is that if the patient certainly is anything other than lordotic, then you lose some of the advantages of a posterior approach. If they're lordotic, then decompressing the cord posteriorly allows the cord to float away from the compression, and the patient should recover. As we've seen, the problem with this condition is that they lose lordosis and many times become kyphotic, so that you really need to be careful. And if they show you someone, if you see someone who is kyphotic and who can't come to at least neutral, even on their extension films they're still kyphotic, then really I would avoid a posterior approach because you're really not going to decompress the cord. The advantage of the laminoplasty is it's good for multi-level disease because you can really do a 3 or 4 level laminoplasty. You need to preserve C2. You can do C7, but it's kind of questionable. You can't go below C7, but you can do the intervening levels pretty well. The advantages are, theoretically at least, it avoids that drifting into kyphosis that you see with a laminectomy, and theoretically it preserves motion. The fact of the matter is that many times after a laminoplasty, patients lose a lot of motion, and the problem with a laminoplasty is patients seem to have a lot of neck pain, more so than with a laminectomy. If you do a laminectomy alone, if you follow patients long enough, they will many times drift into kyphosis. I think it's very unlikely that they're going to offer you a test question where they want you to answer multi-level laminectomy of the cervical spine or the thoracic spine. If they have someone where you say, gee, this is a great multi-level disease, good lordosis, I want to go posteriorly, you either choose a laminoplasty or another option that a lot of people talk about nowadays is a laminectomy and plating. And that's a good option for somebody who has a straight or kyphotic spine, but on their extension x-ray, you can get them back into lordosis. If you can do that, then you can do a laminectomy, get them extended into lordosis, and plate them in lordosis so you keep them there. And that's something that a lot of people talk about doing nowadays. The results of surgery for cervical myelopathy are really very good. Now, this is Bowman's series, and he probably has more experience than anyone in the country in doing this. But he showed that 80% of patients had significant pain relief after this surgery, and kind of synthesizing the numbers, at about 90% had significant improvement in neurologic function. And that's kind of a reverse of what the traditional teaching has been, that patients don't get better, you just keep them where they are. And I actually still tell patients that the conservative goal of surgery is to keep them from getting worse, not necessarily to make them better. And then they think you're fantastic when they get better. But the fact of the matter is that most patients do get better neurologically after you operate on them. The prognosis is most closely correlated with the severity of myelopathy. And this was seen in Bowman's study and Bowman's series. And because it's an easily asked test questions, I don't write for the board, so I don't know what's going to be on it. But I can tell you, this is the kind of thing that's relatively easy to ask because there's a number of factors they can give you. This was the number one thing that correlated. Not that it's a surprise, mind you, but the worse their myelopathy is going into the operation, the worse it's likely to be coming out. Other factors that are significant are the severity of cord compression and the age of the patient, but the severity of myelopathy is number one. The complications are basically the same as they were for cervical disc surgery in general. The ones to kind of focus on for this are particularly airway problems because it tends to be longer surgery. Many times it's surgery on somebody who might have had a Cloward 20 years ago or an ACD infusion 4 years ago or an ACD without a fusion a couple of years ago. So many times it's repeat surgery, more blood loss, longer time, and those are all risk factors for airway problems. So you need to be thinking about that. And when you're taking out the burr and burring down the vertebral body, that's a chance to get into the vertebral artery relatively commonly. Look for a minute at the rheumatoid cervical spine. The cervical spine is involved in 25 to 80% of patients with rheumatoid arthritis. And the wide variation really depends, I think, in the literature on how they selected their patients. If it's an ambulatory population, it's going to be less than if it's somebody who's in the hospital for a hip replacement, let's say. The risk factors or the correlative factors include patients with multi-joint arthritis mutilans. Males have a higher risk of cervical involvement, the duration of the disease, and the use of steroids, although the use of steroids probably just is a reflection of the other things. The steroids probably don't do anything to the cervical spine. The pathology that you see in the cervical spine, there are true synovial joints, both anterior and posterior to the dens. Those joints the synovium in those joints can be involved with rheumatoid pannus, which leads to ligamentous destruction or ligamentous laxity, which leads to instability. The reason patients with rheumatoid arthritis get spinal cord injury is because of cord compression. It's not a vascular phenomenon. It's not something mystical. It's cord compression, and if the problem is either impending or there, if they have cord involvement, then you need to relieve the cord compression. It used to be taught that there was a vasculitis or a variety of other factors, and it was an excuse for rheumatologists not to let their patients have surgery. But that's really a bunch of baloney. It's a mechanical phenomenon, and we're the people to fix it. The patterns that you see, C1, C2 instability, as you know, is the most common pattern that you see. The other ones that you see, most series say that basilar invagination or superior migration of the odontoid is the second most common pattern, followed by subaxial instability, followed by mixed patterns. I think if you take all the mixed patterns, actually, that's probably number 2 after pure C1, C2 instability. It's helpful, and I'm not sure they're going to test you on it, but it's helpful to be familiar with the Ranawatt classification. Ranawatt class 1, you see this in the literature, is neck pain only with a normal neurologic exam. Ranawatt class 2 involves people who have dysesthesias or paresthesias. They can have upper motor neuron findings on physical exams, such as a Babinski sign or hyperreflexia in the arms, but have normal strength. It can be very difficult to do the neurologic exam in patients with rheumatoid arthritis, but to the extent that you're able to do it, these patients have normal strength. And the Ranawatt class 3 patients have objective weakness that you can clearly correlate with their spinal cord disease. And then it's further broken down into patients with weakness who are still ambulatory versus 3B, patients with weakness who are non-ambulatory. Among the things used for diagnosis, really the 2 most important are the flexion extension X-ray and the MRI scan. The flexion extension MRI scan can be somewhat helpful sometimes, but really my partner gets these sometimes and talks himself into doing one thing or another, but I don't really think it's all that helpful. If they have cord compression on MRI, they either do or they don't. But I really think this is the thing. This is what most of the literature is based upon. And there's really a lot of literature that's fairly reliable nowadays on rheumatoid cervical spine, at least at C1, C2, and it's based on the flexion extension x-ray. Tomography can be helpful. SSEPs, I think, are really not all that helpful most of the time. These are some numbers to look at for superior migration of the odontoid, and certainly I don't think you can be expected to remember any of these numbers, really. I certainly can't remember any of them. The line that's most helpful to remember, just sort of qualitatively, is the McRae's line, and that's a line basically drawn across the foramen magnum. Your odontoid never really belongs inside your skull. So if the odontoid is across the foramen magnum, and many times it's easier to see this on an MRI scan than it is on plain x-rays, that's a patient who has basilar invagination or superior migration of the odontoid. A fair bit is known about the natural history of rheumatoid involvement in the cervical spine. We know that atlantoaxial subluxation does get worse with duration of the disease. Now, that's not a reason to tell somebody with 5 millimeters of subluxation, someday this will be 9, so we might as well operate on you today. But we know that these patients are at risk of worsening. A very common pattern that's seen is patients who have a mobile or reducible atlantoaxial subluxation. Then it becomes fixed, and a mistake to make is to say, well, gee, you don't move back and forth so much anymore. What happens is once they get fixed at C1, C2, with the disease still active, the disease sort of gets transferred, and they develop superior migration of the odontoid, which is an even worse, more ominous pattern to see. And it's also well established that cervical myelopathy, once it's present, will worsen and will, in a significant number of patients, lead to death. And cervical myelopathy may contribute to the death of as many as 10% of patients with rheumatoid arthritis. So that it is a very significant concern. And certainly once someone is myelopathic, if they're a reasonable patient for surgery, most authors would, and they have this a fixable problem, almost all orthopedic authors would agree that they need to have surgery for this. One thing that comes up occasionally is, what do you do with the patient who's a pre-op candidate for their foot, their knee, the lesser aspects of orthopedic surgery, if you will, hips, etc. Any patient who has greater than 4 millimeters of motion at C1, C2 is unstable. It doesn't matter if they have rheumatoid arthritis, Down syndrome, or a sprained neck. The numbers are still the same. Doesn't mean you operate on all patients with the same indications, but they still have an unstable cervical spine. And any patient who has an unstable cervical spine needs to be protected when they come to the operating room. And the things to do are, A, alert your anesthesia team that this person has an unstable cervical spine. It's very helpful to have the patient wear a collar to the OR because if your anesthesia team somehow forgets what you just told them, they'll, most of the time at least, look at that collar and say, gee, I wonder what this means, and ask you again why the patient's wearing a collar. And then the patient either needs an awake intubation or some sort of spinal or regional block, if they can have that, is the safest thing. The indications for surgery in rheumatoid arthritis of the cervical spine, the one that's probably the sort of the gold standard in orthopedics, and you know we like things simple in orthopedics, are if the SAC, the space available for the cord, which is the distance behind the dens and in front of the anterior aspect of the posterior arch of C1. If that distance is less than 14 millimeters, then Bowden and Bowman showed that that patient either will have myelopathy or will develop myelopathy, and that most of us feel is an indication to operate. And this is a very easily testable number, question, etc. So if you see that, that's something that I think you should just say, operate on this patient. Now there's obviously some shades of gray in real life, but for test-taking purposes, I would remember that number. If the SAC, or as it was called in their article, the posterior atlantodens interval. I think the JBJS made them make up a new term. Everybody always called it the space available for the cord. The ADI historically has referred to the distance in front of the atlantodens interval, in front of the dens to the anterior ring of C1. You'll sometimes see the term posterior atlantodens interval for the SAC. If you think through it, it's the same thing, and if that's less than 14 millimeters, that's a patient who needs surgery. Certainly, if you're looking at the clinical picture of what the patient is, the gold standard patient who needs surgery is the Ranawat 3A, because that's someone who is markedly impaired, but is still ambulatory, with lots to lose and lots to preserve if you operate on them. So the Ranawat 3A patient, all other things being equal, needs surgery. Some of the other kind of less controversial indications for surgery are patients who are Ranawatt, or more controversial indications rather, the patients who are Ranawatt 2. If they're myelopathic but still have normal strength, I can tell you in my hands at least, I usually recommend surgery in that patient if they have the other indications. And certainly if they have this, I would virtually always recommend surgery. If they're Ranawatt 3B, in other words, they come in a wheelchair, many times those patients will get better. You put them in traction, then you operate on them. Many times those patients will get better, and most people will still operate on the Ranawatt 3Bs, but they're really the high-risk patients. They're going to have the highest complication rate, so that sometimes those patients are not candidates for surgery. Some authors suggest that 8 millimeters of C1, C2 motion or cord compression is an indication for surgery. Cord compression on either myelogram or MRI scan. So certainly if you see a combination of those two things, I think that's a relatively good indication for surgery. If you see progressive instability, they come in with 4 millimeters of motion, and then 5 millimeters of motion, and then 8 millimeters of motion, I think most people would recommend surgery. And certainly the contribution of pain is, I think, poorly appreciated if you read the literature. My experience has been that most patients get excellent relief of their neck pain and occipital headaches after this surgery. I wouldn't operate only for neck pain, but it's something that will tip my hand towards considering surgery. But these are the things they're going to show you. They're going to give you some relatively clear-cut numbers, and you want to remember that less than 14 millimeters, because I guess the article is about 10 years old now, but it's still, I think this is on the OITEs at least every other year, if not every year, and it's a nice, easy number to test on. What are the other indications? Well, if someone has basilar invagination, then basically they need an operation. That's probably the easiest way to remember it. And again, there's some shades of gray with that, but if they show you someone who's symptomatic, who has certainly has any evidence of myelopathy, and they have basilar invagination, they need an operation. And the question many times is, what operation do they need? Or if they have C1, C2 instability, under what circumstances do you go up to the dens? If you see the dens inside the foramen magnum, that's basilar invagination. The Ranawatt line, if it's less than 14 millimeters, a line across the ring of C1, and you drop it perpendicular down to the midpoint of the cervical pedicle, that should be 17 millimeters. If it's less than 14 millimeters, then Ranawatt says that's basilar invagination. And certainly on the MRI, if you visualize neural compression of the dens up into the brainstem, that means they have basilar invagination. The diagnostic criteria for subaxial subluxation, if the canal is less than 14 millimeters, if they have clear-cut instability, certainly the most common thing, because you'll rarely see subaxial disease in isolation. You can, but it's relatively uncommon. It's combined with upper C-spine, and if you have it in combination, you really need to fix all the levels, because there's a very significant incidence down the road, 5-10 years down the road, if you fix someone with C1, C2 disease, that they then develop subaxial instability. So if it's already there, or if there's even a hint of it with these numbers, then you need to operate on them and extend the level or include the subaxial disease. What is the surgical treatment for rheumatoid involvement in the cervical spine? Well, for C1, C2 instability, it's a posterior fusion, and the options would either be wiring. If you wire someone with rheumatoid arthritis, you really have to use a halo. The bone quality that you're going to be dealing with is such that you cannot really get adequate fixation at C1, C2 with wiring alone, no matter what type of technique, and you really should add a halo into that construct. An alternative, which eliminates the need for a halo, is the use of the Moggerel transarticular screws, and I think that nowadays this really is the gold standard for C1, C2 fusion. If the patient, if the anatomical factors, the placement of the vertebral artery, and as long as they're not posteriorly subluxated, as long as you can get them to neutral, this is really the technique of choice, I think, nowadays. It's very rare to need to resect the dens, and if you follow patients down the road who are myelopathic, have weakness, and have a big wad of pannus around the dens and cord compression, if you fix them in situ and get a solid fusion, the pannus will resorb over time. So that the standard answer is to do a C1, C2 fusion almost no matter what the MRI shows in terms of anterior cord compression, and then see how the patient does. Most of those patients will get better and the pannus will resorb. So resection of the dens, a transoral odontoidectomy, should be reserved as a second stage operation. If you have basilar invagination in isolation, then the operation is a occipital-cervical fusion from the occiput to C2. You really can't do occiput to C1 too easily. When in doubt, fuse to the occiput. So if you know you have C1, C2 instability and you have a suggestion of superior migration of the dens, then I would fuse to the occiput. You have a higher, you have a significantly higher fusion rate when you include the occiput, and the downside of missing it is great enough that when in doubt, extend your fusion to the occiput. And the answer for subaxial instability is a posterior fusion with posterior stabilization, not to go anteriorly. The complications are fairly formidable in rheumatoid cervical spine. They include death, infection, neurologic impairment. Infection is obviously a concern in somebody who has an impaired immunologic system, but probably the numbers that people still talk about in the literature and the numbers that a lot of the rheumatologists will quote are really way out of proportion to modern anesthetic and ICU techniques, modern airway management, and you know, certainly if you have someone who walks into your office with rheumatoid involvement in the cervical spine, the major complication rate is still relatively acceptable and should not be a barrier to considering this surgery. Okay, let's ask some questions. You evaluate a patient 1 year following anterior interbody fusion with autogenous iliac bone graft, complete resolution of his preoperative arm pain, minimal neck pain, occasional occipital headaches, current radiographs demonstrate a non-union. You should recommend Dr. Mager. Ed Mager. Right. Yeah, you want to avoid the temptation to jump on somebody just because they have a radiographic abnormality, and this is, to me, a classic question that can be asked, and a thing that comes up in practice a fair amount because there is a significant non-union rate. Many of these patients are asymptomatic and really need to be followed. And the occipital nerve blocks you'd reserve for a lot of occipital, you know, if they really had severe occipital headaches. Which of the following is the most important indicator of clinically significant cervical myelopathy? Dr. Ayers. Gait changes. Correct. Yeah, hand dysfunction is pretty important as well, but this is the one that a lot of the literature is based upon, is the presence of gait changes. 6 weeks following a Smith-Robinson ACD infusion, your patient's only complaint is of persistent hoarseness. He can still express himself to his lawyer. He's not that hoarse. You should order tongue electromyography, barium swallow. Dr. Bakai. Right, direct laryngoscopy. So you guys are going to do great on the test. 64-year-old man has noted difficulty walking times 1 year and has a 3-month history of clumsiness in his right hand. 5-year history of neck pain. He has brisk reflexes. He has an inverted radial reflex. When you tap on the brachioradialis reflex and the long finger flexors fire, that's an upper motor neuron sign, and supposedly correlates with a C6 pathology level. A broad-based gait, and he has dysdiadochokinesia, difficulty with rapid alternating motion. I didn't have to tell you that. X-ray and MRI demonstrate kyphosis from C3 to C7 with cord compression, flattening from C4 to C6, increased signal in the cord at C5. Treatment should include Dr. Wimberly. Right, multi-level corpectomy and strut grafting. Okay, a 37-year-old woman has severe bilateral arm pain, weakness in her wristic sensors bilaterally, an inverted radial reflex on the right, and a Hoffman sign bilaterally. MRI demonstrates a large midline disc herniation at C5, C6. All non-operative treatment has failed. Which is the most appropriate surgical option? Who else is here who graduated from Georgetown University School of Medicine? Yes? Is that it? Just one other? All the other guys? Oh, Dan, okay, good. We'll get to you. Yes? C5, C6. Yeah, I would probably do D, anterior C5 discectomy. If it's a midline disc herniation, unless it's hidden behind the body, you certainly don't want to do a posterior approach because you're not going to get it out. A foraminotomy and discectomy is okay for a lateral disc with a radiculopathy. You don't want to go posterior because neither of these posterior approaches is going to address the pathology. And I think a corpectomy is more surgery than she needs probably. If the disc goes up behind the body, you might need either to do a partial or complete corpectomy. But if you can get at the disc, and I realize without the MRI it's a little hard to assess the pathology, but I think the answer would be D. All right, let's stand up in our street, in our places, stretch for a minute, and get right back to work. All right, back to work. Up. Yeah.
When you talk about spinal cord injuries, there's some literature coming about maybe the ineffectiveness of methylprednisolone.
Yeah, I'm going to touch on.
For the purpose of these boards,
it's still the gold standard. Hey Wade, how you doing?
How are you?
Good.
How was your trip?
Good. Yeah, good. How about you? Good. All right, let's get started. I literally meant the last time I'll do that.
If you have a space available cord less than 14, but you've got no clinical symptoms like a rhino at 1, would you still push the operator? Or would you
They're probably not going to ask you that, but I probably would not. But it's fairly common. They won't ask you that. I don't think. Okay. Let's get to spinal cord injury now. There are still somewhere between 10 and 14,000 traumatic spinal cord injury cases annually. And the tragedy of this disease really is among other things, the population that you see. It's far more common in males, 3 or 4 times as common in males as it is in females. And the mode age, meaning the age at which it most commonly occurs, is 19. It really is, for the most part, a disease of teenagers and young adults, young reckless adults many times, with a secondary spike in older patients who have cervical spondylosis and a narrow canal. It's more common on weekends. It's most common during the summer months. The etiology of SCI is really evolving. The literature historically has said that 50% of cases are motor vehicle accidents, with the rest falls, gunshot wound, and sports, about 15% each. Diving is the most common sport that you see it in. There's some literature to suggest that gunshot wounds, the prevalence of gunshot wounds or the incidence of gunshot wounds is certainly increasing, and it may be as many as 50% of cases, depending on where your center is and what sort of urban centers. You'll have a much higher incidence of gunshot wounds than a hospital that's sitting next to a major highway, for instance. You need to know the syndromes. It's very common to ask you about the spinal cord injury syndromes. And for someone to be a complete, they need to absolutely have no function distal to the level of the injury. And sometimes they'll give you just a suggestion of function, and at least you can eliminate complete. If they have any function distal to the level of injury, they're not a complete. To call someone a complete in practice, and I think they'll give you a complete package on the test, but in practice, theoretically, to call someone a complete injury, they either need to have an intact bulbocavernosus reflex, which is a normal reflex which should be present. If it's absent, it means theoretically the patient is in spinal shock, and the significance of that is only that you cannot prognosticate about whether or not it's a complete injury. Other than that, it doesn't really suggest that the injury is bad or worse, but if they're in spinal shock, theoretically at least, you cannot prognosticate. The bulbocavernosus reflex should return in the first 48 to 72 hours. For all practical purposes, if it hasn't returned after 48 to 72 hours and the patient is still complete, then the patient is complete. And hopefully your rehab lecture will get into a little bit more of this, but if you need to guess a level as to when somebody can do certain things, patients who are a C6 quad, meaning they have meaningful function of their C6 motors, can do much, much more than a C5 quad. Now, they get better at each level, obviously, but there's a big jump from a C5 quad who can really do virtually nothing on his or her own. to a C6 quad who, under the right circumstances, can learn to do lots of things, some independent transfers. They have the tenodesis effect. They can grasp things, and they can even theoretically learn to drive. So if they ask you, if so-and-so can do something, at what level quad can they do it, and you need to guess, I would guess C6, because that's the big jump where a lot of function is at least theoretically attainable if they're a C6 quad. The anterior cord syndrome involves loss of motor function, usually profound loss of motor function, with some preservation of sensory function. It's sometimes referred to as the anterior spinal artery syndrome, and it should remind you of the need to maintain the patient's blood pressure. One of the most important things in treating spinal cord injury patients is getting their pressure to normal or even high normal if you can. And it can be hard to do. They can be in hypovolemic shock. They can be in neurogenic shock, which we'll look at in a minute. The anterior cord syndrome is the one syndrome that may mimic a complete. And you really need to go hunting for signs of sacral sparing or some preserved sensory function. A little bit of long toe flexors, perianal sensation, maybe vibratory or position sense. Many times they have a very poor prognosis for being able to walk, which is certainly the gold standard in terms of recovery. But they're not a complete if they have any of those things. So if they say patient has no sensation except for a vibratory sense at the ankles, that is not a complete. And you really need to read carefully the question before you decide somebody's a complete. The central cord syndrome is probably the most common spinal cord injury that you see. The way I remember or identify picking out a central cord syndrome, and there's lots of overlaps when you look at these syndromes, but hopefully they'll give you something that's relatively clear-cut. The involvement of the upper extremities in the emergency room is going to be worse than the involvement of the lower extremities. So they'll have 3+ weakness in the upper extremities and 5- weakness in the lower extremities. That should trigger you to saying this is a central cord syndrome. Down the road, they'll have lower motor neuron function in the upper extremities because the roots are involved at a couple of those levels, and they'll have upper motor neuron findings in the lower extremities, which is another way to identify this is an old central cord syndrome. In a central cord syndrome, there will virtually always be some, I would say for testing purposes, there will always be some preserved motor function. So if they show you someone who has no motor function whatsoever below the level of injury, then that's either complete or an anterior. If they have preserved motor function, it could be an anterior, but if there's that differential between upper extremities and lower extremities, then it's going to be a central cord syndrome. Central cord syndrome has a good prognosis. Most of the patients will be ambulatory. Most of them will regain bladder control. They'll frequently have a spastic gait, and they'll have clumsiness of their hands, a lower motor neuron clumsiness of their hands. Brown-Séquard syndrome is less common, but it's more common nowadays because it's commonly a sequelae of penetrating trauma. And that involves ipsilateral paralysis on the side of the injury with contralateral loss of pain and temperature sensation, typically 2 levels below the level of injury because the fibers ascend 2 levels, then they cross, then they go up. And this has the best prognosis with almost all patients eventually becoming ambulatory at final follow-up. The complications of spinal cord injury, one of the things they can ask you about is neurogenic shock. In neurogenic shock, a patient, and remember these are usually young adults, will be hypotensive and will be relatively bradycardic. So a young adult who's in hypovolemic shock should have some fairly significant tachycardia to monitor to respond to that. If they show you someone who has relative bradycardia, then that's evidence of neurogenic shock in conjunction with hypotension. The treatment for this is Swan-Ganz monitoring, which can be helpful to differentiate because of the decreased peripheral vascular resistance that you see in neurogenic shock as opposed to hypovolemic shock, and then to be careful with the fluids. When in doubt, if you can't differentiate between neurogenic shock and hypovolemic shock, then you treat them as if they're hypovolemic shock, and most authors are aggressive with the fluids. And if it's clearly neurogenic shock, then the treatment is pressors. The skin is a common cause of, or is one of the most common complications of spinal cord injury, and it's an entirely preventable complication. When you see someone in the emergency room with a spinal cord injury, one of the things that you should be doing, in addition to addressing that, is thinking about these complications. And one of the complications you need to be thinking about, and it rarely is considered, is what am I going to do about this patient's skin? How am I going to get this patient moving early? So you want to get the patient off the backboard and into some sort of situation, whether it's a road arrest bed, which is probably the safest, a striker frame, whatever, but road arrest bed is probably the right answer. You need to be calling for that road arrest bed right away. You don't leave the patient on the backboard because you're afraid he might have a spine injury. You know he's got a spine injury. You stabilize the spine, you get him off the backboard, and you minimize the chances. Skin complications are essentially 100% preventable. Urosepsis used to be the most common cause of death after spinal cord injury. It's now one of the more common causes, but it's no longer the most common cause. The answer to this is a strict aseptic technique in placing the Foley in the emergency room, and then get the Foley out relatively quickly. These patients are going to diurese in about 48 to 72 hours. So most people leave the Foley in for about 48 to 72 hours. And then start on a very aggressive in and out cath program. You have to in and out cath them frequently at first because many times they're still diuresing. So you start with about every 4 hours, and as their residual drops, then you extend it to every 6 and every 8 hours. The goal down the road is for them to have a spastic bladder. So one of the things you don't want to do is catheterize a patient after a spinal cord injury and discover they had 1,200 cc's of urine in the bladder. They can't feel the bladder, and it sets them way back in terms of recovering that spastic bladder if you allow the bladder to stretch out. One of the few life-threatening complications in orthopedic surgery or on an orthopedic examination is going to be autonomic dysreflexia. And you can see this, certainly the classic is in a complete spinal cord injury, but you can see this in incomplete spinal cord injuries as well. And you can see this down the road. It doesn't necessarily occur in the first day or two. They can call you from the rehab facility. Patients will have headache, agitation, hypertension, and it is a life-threatening emergency. The answer is A, check the Foley if they have a Foley, B, catheterize them if they don't have an indwelling Foley in, and C, disimpact the patient. And one of those three things will almost always abort the situation. How do you treat spinal cord injury? Well, the use of steroids is controversial, and the literature that supports the use of steroids is still is under actually more fire nowadays than ever before. But I would tell you, and somebody just asked me this at the last mini break, the gold standard still for test-taking purposes, and unless you're at a center, I think that it has some sort of study going where you're looking at alternatives. I think the gold standard is still to treat the patients in keeping with the NASCUS 3 protocol. And the NASCUS 3 protocol is that all spinal cord injury patients are treated with steroids. The exceptions are, if you don't see the patient within the first 8 hours, you don't start steroids. You also, and this is something I see in practice a lot, you don't treat somebody with spinal cord injury spinal cord injury doses of steroids who doesn't have a spinal cord injury. Just because they have a sprained neck or a broken neck, they don't need steroids unless they have a spinal cord injury. The contraindications include pregnant patients, patients under the age of 13, and the use in penetrating trauma is sort of uncertain. Those patients were not in the NASCUS protocol. Some centers use it, but I think it's unlikely they're going to ask you that in a test. They're going to give you somebody either who's 10, 12, 16 hours out from the injury and expect you to know that you only treat them with steroids if you see them in the first 8 hours, or they're going to give you a classic case of spinal cord injury and expect you to know what the dose is. And they will expect you, at least on the OITs, it's common that you're expected to actually pick among several different dosing regimens. And this is the dosing regimen. 30 milligrams per kilogram per hour over the first hour, and then a 5.4 milligram per kilogram drip over the next 23 hours. If you see the patient after 3 hours, but before 8 hours, then you actually extend the drip for 48 hours. And one way to remember this is if you think of the ideal 70-kilogram man, 30 milligrams per kilogram is about 2 grams of methylprednisolone, which is a whopping dose. But it's a relatively easy way to remember and maybe pick among the things. I realize that there may be other numbers you're trying to remember as well. tibial plateau fractures and other trivial aspects of orthopedics. So all these numbers kind of swim around in your head, but this is something you really need to remember. And this is something that probably ought to be in your wallet or someplace, because you'll get called from outlying emergency rooms, even as you've probably already learned as a chief resident. They say, what do you do? What do we do? You know, they may never have had a spinal cord injury in their hospital. And it is something that I think is still the so-called standard of care nowadays. Other aspects of treatment, steroids, and then the gold standard is still to, if you have a malaligned cervical spine and a spinal cord injury, the standard is to apply skeletal traction and to reduce the deformity. Who do we do that in? Well, certainly it's all predicated on you having an awake and alert patient. And I'll talk at a couple of different junctures in here about the role of MRI before applying traction and reducing the patient. But the one thing is, if you don't have an awake and alert patient, or if you have a patient that you're putting to sleep, or you've intubated, they can't cooperate, then you need to, at the very least, study the patient before doing any sort of reduction. You need an awake alert patient who can cooperate with the exam. Who do you get an MRI scan for suspected HNP? This is still controversial. And certainly there's no one right answer. It depends on your study and who you're talking to, the center you're at. The easiest way to remember, I think they're going to give you a straightforward case, if they give you a case where they want you to know whether or not to get an MRI scan. Certainly, if you have someone who is completely neurologically normal with a dislocated neck, then there's really nothing to gain by an emergent or urgent reduction, and there's lots to lose. And in that setting, most places would tell you, and I think the conservative answer that I would recommend is, get an MRI scan, see if they have a disc. If they have a huge disc that's hidden behind the body, then I think the standard answer is to go anteriorly and take it out. Conversely, if they give you someone who has a complete spinal cord injury, then you have basically nothing to lose. You really can't make that patient a whole lot worse. And you have your only chance of some sort of miracle in the first couple of hours that you're seeing the patient is to emergently reduce it. So that almost any place would tell you, put the tongs on and reduce that patient. The controversy really is the patients in the middle. And if you have someone who has an incomplete cord injury, you can sure make them worse, but you can facilitate them getting a lot better, which they might not get better without just the right treatment. In that patient, if they are awake and alert and can cooperate with the exam and they have an incomplete cord injury, then I think the standard answer would be apply traction, reduce it. Now, I realize this is somewhat controversial. I don't know what else to tell you. Certainly, if you have someone who is obtunded and combative, but you still know they have a cord injury, you do not reduce that patient until you study him, because that's a patient, they need to give you a patient who is an absolute classic indication, and that would be the awake, alert, cooperative patient who has a dislocated neck and an incomplete spinal cord injury. Okay? And the other thing to be aware is, if you're going to take the person to the operating room, put them to sleep, and you think you're going to reduce their neck either open or closed, then that absolutely would be an indication to study them before you would do that. And I know this is, every year, this is one of probably the most common thing I get asked questions about. I'll be at the coffee break. I'm happy to answer 100 questions about this. I don't know that I have the right answers, but this is kind of what I can synthesize from what people are talking and writing about in Common Sense, etc. There are centers that do it other ways, but I don't think you're going to be expected to be on the fringe. Not that Jefferson's on the fringe, mind you, but doing things that you know, they're going to give you a down-the-middle, relatively straightforward question, hopefully. The other thing that it's relatively common is a gunshot wound, and if you remember one thing about gunshot wounds is that the treatment is almost always non-operative. The presence of a gunshot wound to the spine, even when there's a bullet in the canal, is rarely an indication to operate. If there is a bullet in the canal at the level of the cauda equina, there are some surgeons who would advocate removing that. And another thing is, if the bullet has gone through the colon, then the risk of infection is enough that some people would advocate debridement. That's a relatively uncommon scenario, but something at least to think about. And again, I think I went through this relatively. The one question that comes up sometimes, the one thing that may help you, is this acute disc space narrowing. If you see a young, healthy adult who has totally normal discs, this was a 19-year-old kid, and you see here C5 is sitting right on C6, well, the disc must have gone somewhere, and that can be a warning sign somewhere that that person may have a herniated disc behind the body, and you're at risk for pulling that backwards if you reduce this before getting it out. I would certainly get an MRI if the patient's neurologically intact, and I would not get an MRI for a patient with a complete spinal cord injury, and the controversy is really over the incompletes. Just a couple of other kind of golden rules, cheats if you will. In general, if you see someone who has an incomplete spinal cord injury, we're going to go through the specific bony injuries in a minute. If you see someone with an incomplete SCI, they usually are going to have an operation. If we can talk ourselves into operating because you decompress when they plateau neurologically. Now, it used to be that you might wait 6 weeks to see them plateau. Nowadays, some people will only wait 6 hours, and some people will operate emergently in the presence of an incomplete cord injury when there's cord compression. Certainly, if there's one thing on any spine question, whether it's a disc, whether it's a traumatic injury, whether it's a tumor, if you see a clear-cut pattern of neurologic worsening and there's a compressive lesion present, that is an absolute indication to operate. And that's certainly true in trauma, but it's true in almost any aspect of spine. If you see someone who has an incomplete neurologic injury, even for root return, you'll get 1 to 2 levels if you decompress anteriorly, even if you don't facilitate cord compression. And even with a complete cord recovery, and even with a complete spinal cord injury, you may get root return. And in younger, healthier patients, there's an increasing trend towards decompressing anteriorly, even in the presence of even when there's a complete cord injury, just to facilitate that 1 to 2 levels of root return, which we've seen before. The difference between a C5 quad and even a C6 quad is significant. And going from C5 to C7, that so-called golden inch, is a huge functional recovery. So that there's something to be said for decompressing a cord injury even when it's a complete cord injury. And also when you see complete cord injuries, many times surgery is indicated just to stabilize that patient, even if you're not going to facilitate root recovery, because the difference between going to a rehab facility a week after the injury, not needing a halo, versus spending 3 weeks in the hospital and going over to the rehab facility in a halo is very significant. So many times with either cervical or thoracic cord injuries, we will operate relatively aggressively just to stabilize, to get the patient over to rehab early. Let's look at some specific cervical cord or cervical spine injuries. In general, 1 in 3 patients in Bowman's series 20 or 25 years ago now, 1 in 3 cervical spine injuries were missed. And of those that were missed, 5% of patients deteriorated neurologically. Now, hopefully we're not missing 1/3 of C-spine injuries because of heightened awareness nowadays. But the fact of the matter is still, if you miss it, there's still a 5% chance of neurologic deterioration. And the reasons that we miss it are still the same. The presence of multi-system trauma that diverts your attention away from concentrating on the presence of a C-spine injury, specifically the risk of the presence of a head injury or loss of consciousness, were the things that we go by. Does your neck hurt? Can you participate in the neurologic exam? Those things aren't there. Or drug or alcohol intoxication, which make it difficult to examine the patient's neck and to do a good neurologic exam. It's essential to get an adequate x-ray. And you need to visualize the top of T1 to say that you've adequately visualized the cervical spine. Most centers nowadays, if you can't see to the top of T1, then the answer is fine-cut CT scan of all the non-visualized levels. And if the fine-cut CT scan is negative down to the top of T1, and there's no other reason to think that the patient has an injury. In other words, if they have neck pain, if they have a neurologic abnormality, then they're not cleared. But if they have a normal neurologic exam, if they're non-tender, and if you can clear them based on the CT scan, then that's enough in most centers to take the collar off. And there is a significant problem with sending somebody up to the ICU and having their day after day after day with a cervical colic because they don't get the same level of injury. So there's a price to pay for just saying, well, I'm still suspicious, I don't want to clear this patient. When you have the things that you need to clear the patient, go ahead and clear them. Pain-free range of motion, normal neurologic exam, and if your CT scan down to the top of T1 is normal, or your x-rays are normal, you can clear that patient. Atlas fracture is really the most easily missed of all the cervical spine injuries. When in doubt, obtain a CT scan. Only 50% of the time will it be an isolated fracture. So anytime you see a C1 ring fracture, you should aggressively look elsewhere, either adjacent in C2 or lower down in the cervical spine for either contiguous or non-contiguous trauma. Occasionally, you'll see someone who on an open mouth view will have spread of the lateral masses. And if that spread, if you add the right side and the left side, and the combined spread is 7 millimeters or greater, then that means probably they have a transverse ligament injury, which leads to an unstable, which is diagnostic of an unstable C1 ring fracture. That doesn't mean you operate, but what it means is you put them in traction to try to reduce it, put them in a halo, and then you reassess 12 weeks later when the C1 ring fracture is healed to see if they're still unstable. They may still be unstable, and they may still need surgery. You should be aware that transverse ligament injuries can be evaluated very nicely on a CT scan. Many times there'll be an avulsion of the bony tubercle from which the transverse ligament originates. And if there's an avulsion, that has a good prognosis for healing and should be treated in a halo. If it's a pure transverse ligament injury and they're unstable on the flexion extension views that you have, then that's not going to heal and would be a relative indication to operate. But if there's a bony avulsion, they will heal. And when in doubt, if you have a C1 ring injury, when in doubt, I would put that patient in a halo. It's a safe, conservative answer. Not always necessary, but if you're looking for a good guess, put him in a halo. Odontoid fracture, this is the classification with which hopefully you're all familiar. And the concern really is over the type 2 odontoid. If you look at all cases, there's as much as a 30% non-union risk of treating type 2 odontoids in a halo. If you have a type 2 odontoid fracture, the non-operative treatment is a halo, period. The question is, who needs surgery? Now, you can talk yourself into operating on any of them because there's a risk of non-union, but it's helpful if you know the risk factors. The risk factors are 5 millimeters or greater displacement. This is the most well-documented risk factor. And if someone comes in with 5 millimeters or greater of displacement, then that's a relative indication you can justify surgery right away. Now, you can still treat that patient in a halo, but they need to be aware that the risk of non-union with that much displacement initially is at least 50% or greater. Certainly, if you cannot get an anatomic reduction or if you cannot hold an anatomic reduction, then that's a good indication for surgery as well, because the dens is a ring, and if there's overlap of the ring, or if there's mismatch of the ring, then you don't have enough bony apposition to have a significant risk of reduction. They're probably, if they want you to answer operate, they're going to give you a good case. They're going to give you something that's widely displaced to start with and that you probably can't get an anatomic reduction to start with or can't hold an anatomic reduction in a halo. And that's an indication to operate. Don't be afraid to say operate. But if they ask you, if they give you an anatomically reduced, non-displaced, or if they give you a non-displaced type 2 odontoid fracture, that doesn't have a 30% non-union rate. That probably has a 5% non-union rate. And that would be a good patient to put in a halo. Another kind of variable is the elderly patient, because elderly patients, I guess I shouldn't have been quite so definitive about the odontoid. Elderly patients really poorly tolerate an odontoid. So if you get some little old lady with an acute odontoid fracture, that's somebody you don't want to put in a halo. And in the elderly patient, you either put them in a collar and hope for the best and watch them closely, or you operate on them. And I would not be afraid to operate on it. If you can't hold a reduction, if you see progressive displacement of an elderly patient in an odontoid fracture, she's going to wind up with myelopathy if you let it go and go and go. So the conservative treatment is to operate on those patients. And actually, I had a question like this on my board recertification, which was just a few years ago. So even though it may seem like a very aggressive approach in these elderly patients, the thing that you don't want to do is put them in a halo. The right surgery is either a posterior fusion with either wiring or macro screw fixation, or if you can get an anatomic reduction, an anterior screw osteosynthesis is an acceptable answer. You don't do anterior screw fixation if you either are treating a non-union. Some people say you can, but I think that's on the fringe. Or if you cannot get an anatomic reduction, particularly if you have persistent anterior displacement of the dens on the body, then you don't have anywhere to shoot your screw. Or if you have obliquity at this angle, that's the angle your screw goes up. If you have obliquity at this angle, that's perfect for a screw. And one screw probably clinically works as well as two. Mechanically in the lab it may not be as good, but one screw is an acceptable answer. In the type 3, remember, they need a halo as well. Okay, they seem like benign fractures. They have a very high union rate. They have a very high union rate if you treat them in the halo. Hangman's fracture is a bilateral fracture of the pars of C2. The mechanism is a hyperextension injury, typically followed by flexion. The non-displaced Hangman's, the type 1, you may just have had the hyperextension injury with no injury to the disc. Those are stable. And if you have less than 2 millimeters of displacement of a Hangman's fracture, you can actually treat them in a collar. That's a relatively uncommon thing to see. But if you just can barely make out a fracture of the pars of C2 bilaterally with no displacement, no angulation, they can be treated in a collar. Usually these patients will be neurologically intact because if they're not, they're usually going to be dead otherwise. And usually they will heal, no matter how displaced they are, they will heal once you get them even close to reduced. So I would be very, very careful about talking yourself into needing to operate on a Hangman's fracture. The usual treatment is to reduce intraction and then put them in a halo. Now, many times you'll lose reduction with the badly displaced halos with the badly displaced Hangman's if you put them in a halo too early. There's no study that I know of that identifies any degree of displacement it's not like odontoids, as an indication to operate. So even if the best you can do is 3 millimeters displaced, 5 millimeters displaced, 7 millimeters displaced, I would be very reluctant to operate on someone acutely with a Hangman's fracture, with one exception. This is the type 2 Hangman's, which is widely displaced. This is the type 2A, which is not very widely displaced, but when you see this kyphosis of the dens, that needs to go in a halo as well. You reduce them in extension, you don't really put them in traction, you reduce them in extension, and you hold them in a halo. This is a type 3, and I know it's a little hard to see, and this is why you need to be careful, because it looks like a minimally displaced halo, but what it actually is posteriorly, there's a dislocation of the C2, C3 facet joint. And in this patient, this is the one exception. This patient, if you can't get it reduced, which is hard to do, this patient actually does need open reduction of the C2, C3 level, do a C2, C3 fusion, and then treat him in a halo to fix the Hangman's fracture. You don't want to do a C1, C2 fusion unless it's absolutely necessary, because the patient loses a lot of motion. They lose they lose half of their axial rotation if you do a C1, C2 fusion. So in this patient, where the correct diagnosis is made really only on a CT scan, this is the one exception where early surgery is indicated for halo fracture, Hangman's fracture, and it's a relatively uncommon indication. Facet dislocation is a pretty common injury to see. The degree of displacement correlates with the pathology that you see. In general, if you have a 25% subluxation, it's going to correlate with either a unilateral jump, maybe a bilateral perched facets. If you have a 50% dislocation, typically you'll have bilateral dislocation of the facet joints. The degree of cord injury, not surprisingly, is going to correlate with worsening displacement. The typical answer is skeletal traction followed by closed reduction. Nowadays, almost all of us will operate even after you get a reduction to stabilize the patient posteriorly, because the risk of loss of reduction is high enough, or the risk or the problem, even if they have a cord injury, you want to get the patient off to rehab. So really, nowadays, you never see anybody treated in 6 weeks of traction, which used to be the treatment, followed by getting them up in a collar. And if you get them up in a collar or even a halo acutely, there's a significant loss of reduction. If you can't reduce the dislocation acutely, then the answer is an open reduction followed by posterior fusion. And we talked again, and I'm happy to answer questions about what the indications would be for an MRI scan. Vertebral body fracture is at very high risk for spinal cord injury, particularly the so-called teardrop fracture, where you have ligamentous splaying posteriorly and a small chip off the back of the posterior inferior corner of the body of the involved vertebral body. Teardrop fracture is a term that probably should be deleted from your vocabulary because it's kind of, there's a couple of different fractures that some people refer to as teardrop fractures. Be wary of the disruption of the posterior cortex. Anytime you have disruption of the posterior cortex, there's a significant risk of neurologic injury. Be even more wary of the presence of a vertebral body fracture, a burst-type fracture of the vertebral body, and disruption of the posterior ligamentous complex. And that's diagnosed by widening of the interspinous distance on either plain films or MRI. That's a highly unstable injury that's going to redislocate in a halo, and many times if you just try to address this without rigid fixation, you're going to lose your fixation and your strut graft may pop out. Now, if you have a vertebral body fracture and it's stable, then that will heal in a brace or a halo. If you have a vertebral body fracture and you have a spinal cord injury, then most of the time, almost all the time, we're going to stabilize that to either facilitate transfer to rehab, or in the incomplete injuries which recover, you don't want to lose fixation, or you don't want to lose reduction and lose your recovery. So almost all vertebral body fractures with associated neurologic injury are going to wind up needing surgery one way or the other. Beware of the posterior ligamentous injury, and the treatment for that is either an anterior strut, an anterior fusion strut, and plate fixation anteriorly, or an anterior strut and a posterior fusion with plating posteriorly. And that probably is more and more what people are doing nowadays. Be aware of cervical spine injuries and ankylosing spondylitis. These are high risk for cervical spine injury, and they're high risk for delayed neurologic deficit. So you need to really very closely follow, probably admit to the hospital, a patient with ankylosing spondylitis who comes in, who has a significant spine injury. Even if they're neurologically intact, these are patients who will come back 2 or 3 days or a week later where they've got cord involvement. They can have an epidural hematoma. This is one of the few conditions where if you see a worsening neurologic pattern, the right answer might be a laminectomy to evacuate the hematoma, because that is a pattern of injury that you'll see. In general, C-spine injuries and ankylosing spondylitis require a more aggressive degree of stabilization than you would ordinarily apply. So if this is somebody where you say, gee, this is a trivial injury, I put him in a collar. In ankylosing spondylitis, put him in a halo. If this is somebody where you'd say, gee, this is something I could treat in a halo, in ankylosing spondylitis, operate on them. Because they're harder to stabilize operatively or non-operatively. And if this is somebody that you say, gee, this is something I fixed from the back, or I fix from the front, in ankylosing spondylitis, you might want to think about front and back. You may see this in your orthopedic pathology section, but because I think this is important, you should be aware of the difference between ankylosing spondylitis radiographically and other conditions. And the most common sort of confusing pattern is AS versus DISH. In ankylosing spondylitis, you see marginal syndesmophytes. This is ossification actually in the anterior aspects of the annulus fibrosus itself, the so-called bamboo cane spine. In DISH, you see non-marginal syndesmophytes. You see ossification of the anterior longitudinal ligament and the associated spinal ligaments as well. But these are non-marginal syndesmophytes. And a practicing orthopedic surgeon should know the difference and should not tell this patient, you may have ankylosing spondylitis, which is a very significant diagnosis to have systemically, etc. And you should be able to recognize the radiographic difference in those two patterns. One final C-spine injury that I want to talk about a little bit, you may see it in the pediatric lecture as well, is pseudosubluxation, because this is something that will come in occasionally. In growing children up to the age of about 8, but really particularly up to the age of about 4, the facet joints at C2, C3 are quite horizontal, so it's relatively easy to subluxate without a true traumatic injury at the C2, C3 level. The way to suspect the presence of pseudosubluxation as opposed to a true traumatic cord injury is A, there's usually minimal history of trauma. Radiographically, there will be no compensatory lordosis below. So if someone actually has dislocated their neck in the upper cervical spine, which is the most common location, remember, in kids to see from C2 on up to see C-spine trauma, if they've dislocated their neck, they will spontaneously, in the emergency room, have compensatory lordosis below in an attempt to normalize the sagittal alignment of the canal, of the spine. If you don't see that, in other words, if you see kyphosis all the way up, then you should say, gee, that doesn't look like a traumatic injury. That's just a kid who's holding his neck flexed. Maybe he's crying too much, or maybe he's jerking his parents around, who knows. And you should be suspicious of pseudosubluxation. And then when you gently get the kid to extend their neck, it'll spontaneously reduce. That's pseudosubluxation. That's not a traumatic injury. Let's talk about the use of a halo. The halo is the ideal orthosis to immobilize the upper cervical spine, but it really is somewhat unreliable because of paradoxical or snaking type motion in the subaxial region. It's less than ideal for immobilizing the lower cervical spine. It's still probably the best orthosis for the lower cervical spine, but you really need to be careful when you've got a highly unstable situation in assuming, well, I'm putting them in a halo, I don't have to worry. In general, when in doubt in your practice or on a test, I would put the patient on a halo, because you need to be comfortable with the use of a halo, and heck, you may not know how to put one on, but at least you can check the box on the boards, right? So when in doubt, I would select a halo for fixation. But because it only fixes the skull relative to the torso and allows that intercalated motion, it's great for the upper C-spine, but it's not that good for the lower C-spine, particularly a facet jump. And it should not be considered definitive fixation if you have any alternatives in a patient who has a facet jump. There's a number of complications that you can see with the use of a halo, and mostly they occur because of the anterior pins. It used to be very common to put the anterior pins behind the hairline because they look better. The scar, well, you can't see the scar if you've got it in the hairline. The problem is you then are putting the pin in the temporalis fossa. That's where the weakest bone is, and that's also where the temporalis muscle, one of the muscles of mastication, is. That led to a lot of pin loosening and soupiness and pin tract infections. The recommended site for anterior pins is anterior to the temporalis fossa, but posterior to the supraorbital nerve. That's where the best bone is, and that's the correct place to put your anterior halo pins. The problem is it leaves ugly scars. It leaves ugly scars, but that's just the way it is. You didn't give the patient their unstable cervical spine, hopefully. You need to do what's best for the patient now, and if they have scars, they can always be revised afterwards. The standard recommendation now for adults is a total of 4 pins tightened to 8 pounds of torque. You go back 1 or 2 days later, retighten the pins, and then you leave them alone. The most common complication that you see is pin loosening, even when you have them in the right place. And the treatment is to retighten the pins to 8 pounds. If you tighten the pins down and they re-loosen, or they're clearly infected, then you need to replace the pin. If you have a superficial infection, which is the second most common complication, then local wound care and oral antibiotics, and as long as the pin is still stable, is the correct treatment. If the pin is loose and infected, or if the infection does not clear with local wound care and oral antibiotics, then the treatment is to replace it. Discomfort is also very common, and I just don't think there's much you can do about that, and this is one, fortunately, relatively uncommon you really don't want to get. In the pediatric population, under the age of 2, the skin is the skull is so thin that they're really not a candidate for halo fixation. So up to the age of 2, you need a Minerva cast. Between the ages of 2 and up to about 8 or so, you need more pins, and you need to use 6 or maybe even 8 pins sometimes. And you need low torque. Basically, that means finger tightening. 4 to 5 pounds is finger tightening, and it's a lot of pins. But occasionally you do need a halo in these kids. And just like in the adults, if you need the halo, you're not doing the patient a favor saying, God, I can't put a 5-year-old in a halo. That's cruel. you do what's right for the patient, and you actually are doing the patient a favor then. Let's talk about thoracolumbar trauma. In thoracolumbar trauma, in all trauma, you want to think about multi-system trauma, but you need to think about what may be missed sometimes, because it's less likely in thoracolumbar trauma to see head injury, which is a little hard to miss. In the TL spine, you're more likely to see chest injuries, including the thoracic aorta. Some places, any sort of penetrating trauma, any sort of blunt trauma, rather, that comes in as a code yellow or whatever you call it, is an indication for aortogram. Now, that's not necessarily standard treatment, but you need to think about, with a thoracic or thoracolumbar spine injury, does this patient have chest trauma, and could this patient have a thoracic aortic injury, which is easy to miss in a healthy patient who can mount a response for a few hours and then die on the table afterwards. And you need to think of abdominal injuries, and particularly with a chance-type injury, a distractive flexion injury, usually in the upper to mid-lumbar spine, the incidence of associated abdominal visceral injury, commonly from a lap belt, is so high that you really need to have a very high index of suspicion. Now, hopefully you're not seeing these patients by yourself, but you're alerting your general surgeon. But, you go out into some of these rural hospitals, and a femur fracture and maybe a back pain, you may be the only doctor seeing these patients. And when you realize the back pain is a chance injury, that doesn't necessarily mean they call the code team in. So you really need to you need to know these things on your own, particularly those associated traumatic injuries, and then call for a doctor, is my recommendation. At T11 to L1, be aware of the fact that you can have an isolated conus injury or a variety of mixed neurologic patterns. So when you see a T12 burst, an L1 burst, you may just have a conus medullaris injury with inability to void and an abnormal rectal exam, and the legs may work fine. Or if you just pull the sheets up, which the emergency room nurses will do sometimes, and say wiggle your toes, their ankle motors may work fine, and their hip flexors and quadriceps could be completely out. So you really need to be aware of the importance of doing a systematic neurologic exam that starts at T10, sensory and motor function, and works its way down, including a good rectal exam. And do not rely on the fact that somebody else did it, because the general surgeons are not worried about what you're worried about when they do their rectal exam. In general, if the injury is from L2 down, it involves the cauda equina rather than the cord, and has a somewhat better prognosis, and probably speaks to a more aggressive approach in terms of considering decompression. You should be aware of the three-column injury of the spine, and it's certainly not ideal, but you could easily be tested on just the specifics of this. The anterior column involves the anterior longitudinal ligament, the anterior half of the vertebral body. The middle column involves the posterior longitudinal ligament and the posterior half of the vertebral body. And the posterior column involves the posterior elements, and equally importantly, the posterior ligamentous structures like the interspinous and supraspinous ligaments, the ligamentum flavum, the facet capsule. If 2 out of 3 columns are disrupted, then according to Denis, you have an unstable thoracolumbar spine. That does not necessarily mean that the patient needs surgery, but it means that the patient needs aggressive treatment. And it also means that the patient is at more risk for a neurologic injury or more risk at recurrence of their neurologic injury should they have one that recurs. A few pearls, if you will, about what stability really is, because the column theories can be helpful, but what does that really mean? If you have a patient with translation, that's unstable. Not angulation, but if they have translation on either the AP or the lateral x-ray, such as this patient, they have a significant, frequently 3-column disruption of the spine, and that's an unstable radiographic pattern, and that patient needs to be stabilized and fused. Bradford says that the presence of a neurologic deficit is the most important clinical indicator of instability. They may not have any biomechanical correlation, but clinically, when you see a person with a neurologic injury, they have an unstable spine if they have an associated skeletal injury, and they need to be stabilized, either A, to get them into rehab quickly, or B, to preserve any recovery that they may make, even if they make complete recovery in an unstable pattern. I usually stabilize those patients because you do not want to take the chance that they will deteriorate neurologically, which is a significant risk. And that's why it's important in your history taking Person comes in and they're neurologically normal. You want to know what were they like in the field, because sometimes you'll hit on somebody who'll say, you know, for a few minutes I couldn't move my legs, but I'm better now. That's a history of a neurologic injury, incomplete, that got better, and you need to tailor your treatment accordingly, which in my hands at least means you need to stabilize the fracture if they have one. The controversy really is what injury patterns in the neurologically intact patient need surgery. And again, it's the stable injury. Again, translation, always operate. If you see a posterior ligamentous injury in conjunction with a vertebral body fracture, particularly, well, whether it's an apparent compression fracture or a burst fracture, when you see widening of the interspinous distance, when you see dislocation of the facet joints on the x-rays, when you examine the patients and they have ecchymosis posteriorly, where your finger falls into a gap between the spinous processes, when they're markedly tender to exam. You know, a burst fracture, usually they don't hurt that much when you palpate their back, but when they are really tender to palpation, even the Gray Turner sign can be evidence of dislocation posteriorly and retroperitoneal bleeding. All of those things can tell you that you have posterior ligamentous injury, and that is an indication to operate in the presence of a vertebral body fracture. In the burst fracture, which is really kind of the classic thing that gets argued about, in general, I would recommend that you consider operating if there's canal compromise greater than 50% by the burst fragment, which you see very nicely here on this CT scan. If you have kyphosis that's greater than 20 degrees compared to what's expected for that level, from T10 to L2, the spine's straight, and then it starts to become lordotic. Or if you have compression that's greater than 50%, loss of height that's greater than 50%, all of those should be considered relative indications, even in the neurologically intact patient, to consider operating. Now, I don't advocate necessarily operating for any or all of those, but you should at least think about that. And those are the numbers that you see in OKU, I don't know, 6 or 7 or whatever they're up to nowadays. The big thing about the compression fracture is that when you see an acute compression fracture that's non-pathologic in normal healthy bone, if it's greater than 50% loss of height, it's not probably a compression fracture. What it means is it looks like a compression fracture to the emergency room doctor, but when you go back and look, you realize there's posterior ligamentous disruption, and that's a highly unstable pattern that needs surgery. We talked about the indications for surgery in the burst fracture, which is a very common injury. The hallmark of the burst fracture, it is an axial compression fracture where you see loss of height of the anterior cortex and loss of height of the posterior cortex. When you see those two things, it is not a compression fracture, it is a burst fracture. A compression fracture, you see loss of height of the anterior cortex alone, and the posterior cortex will have retained its height. Decompression is indicated and can be done either anteriorly, which is usually in orthopedics what people write about and talk about, or it can be done posteriorly. You cannot decompress a burst fracture with a laminectomy alone. You need to do a posterolateral decompression. The results are equally good if you're good at doing a posterolateral decompression, and I would tell you that most people are not. And most of the people who may be surgical colleagues, let's say in your hospital, who say they are, probably are not. And that the most consistent way to get a good decompression, and certainly would be indicated for late decompression, would be an anterior decompression. But in the hands of people who are good, a posterolateral decompression is an acceptable approach where you drill down the pedicle and tamp the anterior cortex, tamp the anterior fragment back into the vertebral body. You do nothing to decompress a burst fracture by doing a laminectomy. If you do an indirect decompression where you restore the lordosis and the height of the vertebral body, you will decompress the canal by about 50%. Now, whether that's enough or not depends on the clinical situation, but you rarely will get a complete canal clearance by just a so-called indirect decompression. In terms of stabilizing a burst fracture, you need to be very careful if you're going down to L3 or lower that you avoid just distracting and distracting. It's great for reducing the fracture, but the problem is if you're down into L3, L4, and certainly, well, even into L4, you do not want to see any loss of lordosis, or you're setting the patient up for a problem down the road, which you may be out of practice by the time they need treatment for, but it's not the right answer. So you need to be careful about that. And you need to be very careful about fixing a burst fracture with only 4 pedicle screws. There is a 50% incidence of either late kyphosis and or screw breakage if you fix them with pedicles one above, one below, without either reconstruction of the anterior column or some sort of supporting fixation distally, either screws and hooks at a single level, or what some people do is go 2 above and 1 below with screws and hooks. Be aware of the fact that if you have a burst fracture and an associated laminar fracture, which is a very common anatomic pattern to see. I don't know if we see it here, but it's a very common pattern to see. There is a 34% chance that if you explore the canal, you will find a dural tear as well. Now, the clinical significance of that is not entirely clear, and in fact, I would suggest in most cases there is no clinical significance to that. But that's in the literature, and it's something they could test you about. If there is a burst fracture and a laminar fracture and an associated neurologic deficit, then the chance of finding a dural tear at surgery is as high as 74%, and many times you will find a nerve root entrapped in that laminar fracture. And some people do feel that that's an indication to go posteriorly to remove those nerve roots from the laminar fracture if you think they're in there. And certainly if on your imaging you can clearly see that there's roots in the laminar fracture, that would be an indication to go posteriorly. I think this is kind of testable stuff, but in my practice at least has very little significance in terms of my decision making. The chance injury is a distractive flexion type injury. Classically, it's described where the patient rotates into kyphosis and is distracted posteriorly around a lap belt. Be aware of the association of abdominal visceral injuries. Your general surgeon should be aware when they see a lap belt injury with abdominal visceral injury that even if the patient doesn't have back pain, they should x-ray the back looking for this. If you have a pure bony chance fracture, then that patient can be casted or braced. I would be very careful about bracing most of the patients who come in with thoracolumbar spine trauma because I think they tend to be relatively unreliable. So if the patient's not a candidate for a cast, I would rarely rely on a brace alone. If it's a soft tissue injury where the fracture pattern goes through the ligaments, through the disc, or a combined injury, bony and soft tissue, where most of the fracture goes through soft tissue, or if you have an unreliable patient, or if you have a patient who's not a candidate for a cast, let's say they need more abdominal surgery, or if you have a patient where you can't get an anatomic reduction, then the treatment of choice is surgery consisting of a compression implant and fusion. And that can be a short segment implant, even one above and one below. What that means is that many chance fractures can be treated or need to be treated surgically. But sometimes, if you have a pure bony chance, particularly in a thin patient, reliable, you can put them in a cast. One final variation is the low lumbar burst fracture. And about 4% of all spine fractures will be burst fractures of the low lumbar spine. Because the spine is lordotic in this area at L4 or L5, it affects the mechanics of healing. The spine is not wanting to rotate into further kyphosis. Usually you will preserve the alignment that you have so that the treatment for this is usually non-operative. The exceptions to that would be either someone with a significant neurologic deficit, like a complete cauda equina syndrome, a profound degree of weakness in one or both legs, or certainly a progressive neurologic deficit, or someone who has either severe deformity with marked kyphosis, or someone who has progressive deformity, where you say, well, I'm going to put this in a cast, and then over time you see them rotating into more and more kyphosis. Those would be indications for surgery. The problem is the downside of surgery. It's not that easy to do an L5 corpectomy and stabilization, or even L4. You really don't like to do an L2 to the sacrum fusion or an L3 to the sacrum fusion. So when you weigh the pros and cons of surgical versus non-surgical treatment, the cons of non-surgical treatment go down, they usually do okay, and the pros go up significantly. So in general, guess non-surgical if you're faced with an L4, and certainly an L5 burst fracture would be best treated non-surgically. Okay, Dan Keefe, a 59-year-old woman with a long history of seropositive RA, neck pain and worsening occipital headaches, positive Babinski sign bilaterally. Radiographs demonstrate 5 millimeters superior migration of the dens, 8 millimeters C1, C2 motion, SAC of 13 millimeters inflection. Treatment should consist of, what do you think? Yes. Clear-cut posterior migration, clear-cut superior migration of the dens in addition to C1, C2 instability. So absolutely. When in doubt, include the occiput. Okay, a 19-year-old man sustains bilateral C5, C6 facet dislocation and central cord injury. Skeletal traction is applied, but closed reduction cannot be achieved. MRI shows an extruded disc herniation behind the body of C5. Management should now consist of... Anybody else here from Georgetown? Yes. What? Speak up again, I'm sorry. D? E? Yes. Anterior C5, C6 discectomy. There might be other, you could do an anterior plating conceivably, but the other options are really unacceptable. And certainly with an incomplete injury, to put the patient to sleep and do an open reduction would be contraindicated, I believe. And I think that would be the standard answer. Okay, 31-year-old woman injures her neck while skiing. She is neurologically intact. Type 2 odontoid fracture, 8 millimeters of posterior displacement. Posterior displacement in type 2 odontoids is another relative risk factor for non-union. It's never really been as well correlated as the degree of displacement, but it's another thing kind of have back in your memory banks. Okay, who's making the mistake of looking at me right now? Yes. Right there. C. Right. Yeah, you could put her in a halo, but most patients are not going to choose 12 weeks in a halo with knowing that they have a greater than 50% chance of needing the definitive treatment. Some will. Anterior screw osteosynthesis is another option, but we didn't give it to you here. And the SAC is just a red herring. Okay, 26-year-old woman extricated from the back seat of a car involved in a high-speed wreck, large transverse abdominal wall abrasion, laparotomy, has a sigmoid colon injury. Which associated injury should be suspected? Anybody call out the answer? C, chance fracture. Okay, 68-year-old man falls down a flight of stairs injuring his back. He has an incomplete neurologic deficit which resolves after the administration of steroids. AP and lateral radiographs demonstrate a severe compression fracture, 4 millimeters of anterior translation, 3 millimeters of lateral subluxation. Appropriate treatment would be you observe him for 48 hours and then yes. D? Right. Yes, D is the answer. He's recovered neurologically, so the indications for decompression is somewhat less. With these highly unstable injuries, in general, even with more advanced anterior fixation systems, you really can't stabilize someone as well anteriorly as you can posteriorly. This is a highly unstable fracture, and the standard answer would be to stabilize him posteriorly, and then if he were to need decompression, now if he's still neurologically normal, I wouldn't decompress him, but if he were to get worse, or if he hadn't recovered neurologically, I would still stabilize him posteriorly first because it's so unstable, and then go anteriorly, if need be. What time is it now? 9:15. Let's do lumbar disc disease, and then we'll stop. Just a word about low back pain in general. As hopefully you're aware, as the lay population knows, 50 to 80% of individuals will have a significant episode of low back pain sometime during their lifetime. And the estimated cost, and this is the direct medical cost, let alone the indirect cost, is as much as $100 billion annually. That's a heck of a lot of money. So it really is a very significant public health problem. You should be aware that we know a lot about the natural history of this. 90% of people with acute backache will undergo spontaneous resolution of their symptoms in the first month. And that means basically watchful waiting is the appropriate treatment. The risk factors for back pain in general include obesity, smoking, and men are at greater risk than women. Lifting on the job, a history of significant lifting, a history of vibration, particularly related to driving, or chronic prolonged sitting. And some studies show that the most common risk factor for an industrial back injury is dissatisfaction with your job. When you evaluate the patient with acute low back pain, really in addition to trying to manipulate him in such a way, or she or her, that they think you're responsible for when they get better by the next week, you want to rule out red flags, because that's the one indication to do something other than watchful waiting. And red flags would include some evidence of either tumor or infection, like systemic symptoms, weight loss, fevers, chills, etc. A significant history of trauma. Patients will sometimes come in and say, you know, I fell off the roof the day before yesterday, and I was able to get up and walk, and I was embarrassed to go to the emergency room. That's somebody who probably needs an x-ray, as opposed to somebody who says, I woke up the day before yesterday, and I can't move my back. And I can tell you a lot of doctors in emergency rooms get x-rays on the latter patient. So a significant history of trauma is an indication to get x-rays acutely. Or evidence of cauda equina syndrome. Urinary retention is the classic symptom of a cauda equina syndrome. And you have to wade through a lot of times in your history taking, because a lot of people have bowel and bladder complaints that they're more than happy to tell you about chapter and verse. But you need to focus in on what's significant. But if you see somebody who says, yeah, I have horrible back pain and the back of my legs is numb, and yeah, you know, I've noticed I can only pee when I stand in the shower, that's very significant. The indication for imaging would be to pursue red flags. And although the standard is probably to get x-rays, x-rays in your office really virtually tell you nothing most of the time. And I almost never get them unless I suspect a deformity or somebody sent in to evaluate a deformity. Really the best test is an MRI scan. But the only indication to get any imaging study in the first month of an acute backache would be if you suspect a red flag, such as tumor, infection, significant trauma, or a cauda equina syndrome. If they fail non-operative treatment, then I don't necessarily think you have to image them in a month, but that's when you start thinking about imaging them. And certainly in a month, 6 weeks, it's not unreasonable to consider plain x-rays. And someone with significant back pain who has impaired activity level, etc., I don't think it's unreasonable at 6 months to consider an MRI scan, although it rarely leads you very far. But you do not want to image these patients in the first month, and that's the kind of question they could easily ask you. Lumbar disc disease is most common at the L4, L5 level. It is believed to occur, and again, it's part of the normal aging phenomenon, but it's believed to occur as a result of recurrent torsional strains that lead to tearing of the outer fibers of the annulus. Those tears coalesce and will lead to bigger tears, which under some circumstances can lead to an actual herniation. Lumbar spondylosis, just like cervical spondylosis, involves desiccation, loss of water content of the disc, collapse of disc height, progressive arthrosis of the facet joint, which is a significant part of the pathology of that three-joint complex. You see disc bulging, osteophytosis. All of this leads to abnormal kinematics of the motion segment, which leads to further degeneration. The question really is, what's the significance of this? Again, there's abnormal MRI scans in asymptomatic patients in the low back as well, even better defined for the lumbar spine than for the cervical spine. And because it's even better defined, there's probably, if you're a gambling man or woman, you might think that this might be where you'd see a question rather than the C-spine. This is a little more busier than the C-spine. Between the ages of 20 and 40, about 20% of patients, asymptomatic persons, not patients, will have a disc herniation, and somewhere between a third and a half will have bulging or degeneration of the disc. Between 40 and 60, still only about 20% will have disc herniations, but the risk of degeneration and bulging goes up. Between the ages of 60 and 80, the risk of HNP surprisingly actually goes up, and then you start to see a significant risk of stenosis. Again, these are asymptomatics, and almost a universal prevalence of degenerative changes, bulging or degeneration of the disc. With lumbar discs, as opposed to cervical discs, there are two different types. The classic disc herniation is a posterolateral disc herniation, and at the L4, L5 level, a posterolateral disc herniation will get the lower numbered root. 90 to 95 to 98% of disc herniations at the L4, L5 level will get the L5 or lower numbered root. But in the lumbar spine, you can get a foraminal or far lateral disc herniation. You should be able to identify that radiographically on an MRI scan, and certainly if they tell you that it's a far lateral disc herniation, then you should be aware of the fact that the upper root, the L4 or exiting root out in the foramen, is the affected root. I think they will give you if they just say it's a lateral disc herniation, you need to be a little careful. But if they tell you this is a far lateral disc, or this is a foraminal disc herniation, or if they show you on a parasagittal MRI scan a foramen filled up with disc material, you should be aware, you know, at L4-5, that ain't L5, that's L4. And again, you need to know the neurologic findings, which really should be gimmies. And Hoppenfeld's book on physical exam and Hoppenfeld's neurology little treatise is really fantastic. And you shouldn't leave your residency without knowing these things anyway, let alone pass your boards. The diagnosis of lumbar spine problems really is primarily based on history of physical examination. X-ray is a very limited utility. You wait 4 weeks, and it is really relatively nonspecific. This is a poster child for lumbar disc disease, vacuum disc phenomenon, traction osteophytes, discogenic osteosclerosis in the vertebral bodies, sclerosis of the disc, loss of disc height, retrolesthesis in an asymptomatic patient. EMG and nerve conduction velocity testing is really of very limited utility as well. Certainly in first-time low back patients, patients with lumbar radiculopathy, I don't think an EMG tells you anything that a good physical examination doesn't tell you. The nerve conduction velocity testing can be helpful sometimes in differentiating neuropathy from a radiculopathy. That's more of a stenosis situation, usually in elderly patients. It can sometimes help sort out in a confusing picture in the multiply operated back, and it can, you didn't hear it from me, can get the patient out of your office sometimes while you catch your breath and think what you're going to do with him or her next time. But really, in general, this is a needless use of medical resources, I think, in 99% of patients, even patients who are going to go to the operating room. Neuroradiographically is, again, there's a high risk of asymptomatic normals, so you need to not just jump on MRI scan every time you see somebody, and you need to be careful when they come in from their friendly family practitioner with an MRI under their spine, a week's worth of back pain and some tingling in their big toe, saying, gee, this is an operative case now. It really should be thought of as a preoperative test. You should be aware that the tension sign is the most important, most predictive physical finding. And most of the time, since most lumbar disc problems occur at L4-5 or L5-S1 and involve the L5 or the S1 roots, most of the time you're looking at the straight leg raising sign. The straight leg raising sign can be done sitting or supine, and it should reproduce the patient's pain or paresthesias somewhere between 30 to 70 degrees of hip flexion. If the hip is already flexed, then somewhere about 30, in a sitting straight leg raise, at about 30 degrees or so of getting the knee out straight, it should reproduce their symptoms. It is physically impossible to have a positive straight leg raising sign in a patient who doesn't have leg pain. So it's kind of a meaningless test. I will dictate in my note, straight leg raising, reproduce back pain only on the right or the left, but it has no real significance in terms of decision making. It's important only to the extent that it reproduces their radicular pain. It is the most important, most predictive physical finding and really should be thought of as a necessity to identify someone for surgical treatment. If you are bringing someone to the OR, either on your test or in your practice, and they don't have a straight leg raising sign, and the operation is lumbar discectomy for radiculopathy at L4-5 or L5-S1, you really need to ask yourself, am I filling in the right circle, or am I doing the right thing for this patient? Because many times the answer will be no. If it's L3 or L4, then the femoral nerve stretch test is the appropriate tension sign. Even people with herniated discs, 90% or more of them will get better without surgery. Most will improve in the first 4 to 6 weeks, and of those who don't improve in 4 to 6 weeks, most will get better at 12 weeks. This is why we wait typically at least 6 weeks to consider operating. There is some theoretical evidence that after 12 weeks the results of surgery begin to deteriorate. I certainly wouldn't push someone to have surgery as we get to that 12-week point, and I would not withhold surgery from somebody who's 6 months or a year or even 2 years of radiculopathy if they're good surgical candidates otherwise. The operative and non-operative results are equal at 4 years, begin to come close to equal at 1 year, and the reason for that is the long-term problem is back pain. This is an operation that's great for taking away their sciatica. And the good surgical candidates are the candidates who are going to go find another doctor if you say, well, all you got to do is wait a year with this and it will get better. The patients who wonder, gee, maybe I could wait a year or 4 years for my results to get the same, they probably should wait a year or 4 years. It's the patient who cannot live anymore with their leg pain, not their back pain, their leg pain, that is a good surgical candidate. In general, non-operative treatment is usually best and is almost always best early on. And again, sort of the standard gamish of non-operative treatment, rest, moist heat, non-steroidal anti-inflammatories. I find injections to be very helpful, and I think certainly should be something to think about. In the acute red-hot disc, it gives you time to let the natural history take its course, and it's somebody who's ambulatory, not quite sure how they're going to do. It may get them to that next level where they're clearly best off treated non-surgically. The indications for surgery, absolute indication would be a cauda equina syndrome, manifested typically by urinary retention. A relatively absolute indication would be progressive weakness, a person who comes in with progressive, significant weakness. Not just an EHL that you thought last time was 5- and now it's 4+, but clearly getting worse. Be aware of the fact that many times patients will come in with a lot of weakness, and when they're in terrible pain, they can't fire those motors. Those are the patients who you convince yourself, and hopefully them, in the recovery room that not only did their pain go away, but lo and behold, their strength got better. Their strength gets better when their pain goes away, and if you get them an epidural shot, many times their strength will get better as well. But if you clearly have progressive weakness, that's an indication to operate. It's very uncommon in my experience in lumbar disc disease, actually more common in stenosis. Far and away, the most common indication is persistent, disabling back pain. The ideal candidate for a lumbar discectomy has 4 things. Their chief complaint is sciatica. That's the thing they talk about the most. It can be primarily in their buttock, but it should go below the knee in a clearly dermatomal distribution or with pain and or paresthesias. It's nice for them to have an abnormal neurologic finding, although it can be subtle, a little bit of sensory change, a little bit of weakness. They should have a tension sign, and finally, they need to have a confirmatory MRI. Same side, the same level you guessed preoperatively, maybe you're off by a level, but anything more than that, you need to be very careful about just going on a fishing expedition. And they need to have failed non-operative treatment, because they can have all 4 of these things and still get better non-operatively. If they have all 4, and if they fail non-operative treatment, 95+ of them are going to do great. They're going to do great if they're in terms of relief of leg pain, not necessarily back pain. Somewhere between 15 to 30% will have significant back pain, and they need to be aware of that preoperatively. Only 50% of patients will make a complete recovery of motor or sensory function in the old studies, which there's no reason to think our studies today are any better. And only 25% will get their reflexes back. And if you practice in a city with lots of yuppies, they'll come in having practiced their reflexes following the surgery just to see, and will want to know why they haven't become normal again. And the complications include dural tear, about 1%. This is you should be aware that the treatment is to repair the dural tear watertight at the time of surgery. If you can't, patching or some other treatment, but you don't leave leaking CSF at the time of surgery except in the most extraordinary of circumstances. If they have recurrent CSF leakage postoperatively, a perfectly acceptable treatment, and one I think you might be asked about, is placing a subarachnoid drain at the bedside, let it drain for 4 or 5 days, and most patients will have a resolution of their CSF leak. Recurrent disc herniation occurs between 3 and 11% of patients. It's not necessarily an indication for surgery, although it can be. It should be treated non-operatively at first. Discitis is rare, but it does occur, typically somewhere between 3 to 6 weeks after surgery. The patient will call with the relatively sudden recurrence of severe back, maybe buttock pain, not necessarily their radiculopathy, and they will not leave you alone. And when you see that, you should be aware of that complication, and it's amazing how often this goes missed. The test of choice is an MRI scan with gadolinium, not to look for recurrent disc herniation, but to look for increased enhancement in the disc space. And then vascular catastrophe. If you get bright red blood out of the disc space, you need to aggressively treat the patient in terms of flipping them over and calling for help. Okay, why don't we stop there? I think it's about 9:30. Dr. Miller has an announcement.